Happy Friday, everybody.
Happy Friday.
Cameras are certainly not required for this, but you are more than welcome to turn yours on if you wanna show us your wonderful face on this Friday. No pressure though. We are going to go ahead and kick things off. I'm sure we'll have some more people hop on as we go along. But we only scheduled half an hour for this. We've already got a number of questions that were submitted, so I don't want to waste any time. I do want to say welcome to our first AMA. This is a new kind of webinar-ish session that we're doing, and I'm excited to feature Deirdre's brilliance and insight and experience about the hospital at home care model. There are probably 100 different things we could talk about when it comes to what these programs look like. So we're just going to start with, whatever y'all want to talk about. We have a number of questions that were submitted in response to our email already, so we are going to start with those. But if you have something that you would like to ask as well, we should have a Q&A box working in this meeting. Let me make sure we've got chat, polls, Q&A down there at the bottom. So if you have a question you want to make sure we get to, please put something in that box. You don't have to type it all out. We will call on you to unmute yourself and ask it. Just say, I have a question about whatever, enrollment or eligibility or staffing or whatever the case may be. And then we will get to as many as we possibly can in our time together today. If you haven't had the pleasure of meeting Deidre Rolli yet, apologies that her box currently says Rachel Bowman, but she is Deirdre. Deirdre is one of our clinical consultants here at Current Health. She comes to us with deep expertise and experience in the hospital at home care model and was instrumental at building that program at Umass Memorial Health. In her role at Current, she works closely with a number of our hospital at home customers, advising and consulting and doing a lot of boots on the ground strategizing about how to optimize these programs and overcome the many challenges and hurdles that they often face, as everybody is pretty much still doing this for the first time. So it really does feel like we're on a grand adventure together with these. I'm going to start with, we have a question from Vincent. He asks, for those participating under the CMS waiver, what's their average daily census? And also the same question for those not participating under the CMS waiver.
Sure. I'd just like to start. Thanks, Katie, and thanks for everyone that joined. And I see some familiar names and some people that I haven't met yet. So we'll dive right into the first question. And thanks, Vincent, for sending this along beforehand. When we're talking about CMS waiver and non-CMS waivers, I really think that you need to think about what the geographical location that your program actually covers, because that's going to really take a toll on how many patients you can actually get onto census in either case. Programs that are on the CMS waiver only covering the Medicare patients, their census is a little bit lower than programs that have other payers. And I would say that in a small geographical location, that's probably 2 to 3 patients a day. Whereas you add more payers, the grander you can scale your program. It's also, I just want to point out that when you are planning to think about what the mile radius is that your nurses and your staff can actually go out from your medical centers. And that should be really done in the early phases on what communities you're actually going to serve. And then thinking ahead, I always try to give the advice that if you look at where your patient population is coming from into your hospitals, to try to capture those patients on the metrics that your hospital has to offer for next place of expansion. So I hope that that answered your question. I think you're on mute, Katie.
Yeah, thanks. We do have a question here from Ashley, who asks us, what are the top drivers for increasing patient volume in a hospital at home program? One of the top questions, I feel like.
It is such a struggle in a sense to answer this fully, but I would say A top driver is to get, you know, surprisingly, you know, the way that I think about it is you need to market your program right from before launch. And surprisingly, even with the hospitals being at 120% capacity, there's still a lack of trust in the care model. And so what I would really recommend is that you have champions when it comes to specialty services that actually will be able to speak to the model, so that patients get pushed to you in a sense. So you're not trying all day long to be getting patients out of your medical centers. I also would recommend that you meet with case management, nurse managers, anybody that has to do with bed flow in your hospitals. Get the word out, and it needs to continue, not just from day of go live. This is an ongoing process, and the more people become familiar with the program and the success of the program, you're really going to see the I like to call it a push referrals coming in, just because they really want to see what success you're doing. And another key point to I guess to express the success, or to keep, you know, the clinicians in the brick and mortar confident on your program, is I always encourage that when you're sending like a little thank you note for the referral out, just to give the clinical course of your patient with really good data on how successful they did in your program, because the more that they see that your patient was successful, the more referrals that you're going to get, if that makes sense.
Yeah, this is certainly a huge topic, isn't it, Deirdre? And one that we've talked about a lot. I do want to do a quick plug. We have been building internally a best practices guide about this topic specifically. So what are the different factors across the different areas of a program, from culture to technical workflows and integrations to that ongoing proactive work that it really does take to build up the both, as you say, the push and the pull sides of that referral kind of situation. I think one of the really interesting things that your team did at UMass was have a multifaceted approach when it came to pulling those patients. As you mentioned, that really dedicated outreach to specialists, to the hospitalist team, and also putting the pieces in place so that once you've got that momentum happening with the awareness and the engagement and that trust that you've built, you can start to transfer some of that enrollment volume to that push side, where you're actually getting the facility clinicians recommending and referring patients to you directly on their side. So there's certainly no magic bullet though, right? Like there's so many pieces that go into building that census.
You know, absolutely. And just to build on that, you know, Katie, is you think about what services really benefit from a hospital at home program. And you really, cardiology and CHF patients really, really do well on these programs. And I can give you an example, you know, is we had a patient when I was at UMass that had multiple hospital admissions over a year, had never even been able to make it into her primary care with her CHF, because she would be readmitted within 10 days. And bringing her onto that hospital at home program and giving her 2 extra days of diuresing and, you know, that hard one-on-one teaching with her and the family, she actually didn't get readmitted for 6 months. So just that key win and expressing that to the physician that we could do this safely, more referrals are being pushed to us. So it was a great thing.
Yeah, love that. Our next question comes from Sarah, who asked, I would like to ask about the nursing workload for hospital at home. What's the staffing ratio and how is it reported on whether, like, how do you know whether that staffing ratio is adequate? She notes in traditional inpatient units, it depends on the acuity and may be reported on using workload reporting, flow sheets, et cetera, to monitor.
Yeah, so there's different aspects when it comes to taking care of the patient. Really, it is how long does it take to drive to get to your next patient when you're thinking about how to build your assignment. I would really say that a sweet spot for a nurse that's a 12-hour shift is to do a 3 to 4 patient assignment. That gives them, you know, their 2 1-hour visits that are required by CMS, plus some travel time in between. And then you need to keep in mind that when you're taking an admission onto the service, those admissions actually take 90 minutes. It's a long process to get them on. So a real sweet spot is 3 to 4 patients per person. And then if you have a more acute patient, then that nurse would take the 3 patients, and the nurse with less acute patients would take the 4 patients. So just thinking about drive time in between and building that in. I also like to say that in comparison to an inpatient unit, where the usual ratio is probably five patients to 1 nurse, I tried to break it down when I was building staffing for UMass into hour blocks. So if it's just like I had said, if it's a 12-hour block and they have 4 patients, that's 8 hours. Then they need to have their lunch break. So there's 9 hours, and then you give them about a 15-minute drive time in between homes.
Yeah. So probably worth noting that probably changes a little bit for programs that use like the MIH model for those field visits, right? How do you like you're mostly focusing those ratios on the like field nurses, I think we sometimes call them, right?
Absolutely. So those would be field nurses. MIH, which is the mobile integrated health, or community paramedics, actually can go out and do in-home visits also. If we were talking about monitoring nurses, I would say that they could probably do a 20 to 1 ratio. When you're really starting to think about how to staff that department, a monitoring nurse would be 20 to 1. When it comes to physician staffing, when video visits need to be done before, say, 1 o'clock in the afternoon, and you start your day at 7, it's tough for a doc to get a video visit in on more than 12 patients. And that's pretty much what they're carrying on a hospital service too. So just keeping all of those factors in mind, you try to keep it, right directly linked to what your hospital would be doing usually.
Cool.
Yeah.
Our next question is from Marlene, who notes they have a few questions asked, but the top one is, does your hospital at home model include pharmacy services? And if so, what is the model, hospital outpatient or community pharmacy? And if not, how do you manage the?
Thanks, Marlene, for this question, because, it depends state to state. It depends on really what your board of pharmacy in each state requires. At UMass, just from my experience, we were using inpatient pharmacy for all medications, but the state of Massachusetts doesn't allow narcotics to be dispensed, and the pharmacy can't compound medications. So it turns into maybe having to do some third-party investigation. So it really does depend on the state. Workflows that you can build with your pharmacy is to make sure if you're using your inpatient pharmacy that you're getting 24-hour supplies into the home for the patient. And just to keep in the back of your mind that you might have med dose changes. So you're going to have to figure out, is that based on lab work that needs to be drawn in the morning. So it's really working with your fellow colleagues within the pharmacy to come up with your own workflow. But I can give you tips later and let you know how to build those workflows. But really, like I said, it really depends on what state you're living in on what to do.
Thank you, Deirdre.
Yeah.
Our last previously submitted question comes from, I believe it's Pantia. I was wondering if you have any evaluation plan in place for existing programs, and if so, could you share the metrics you've used to evaluate those programs?
Yeah, so at UMass, we used Tableau, and we had a great data scientist that worked out at Epic. And metrics that we were measuring, like most programs across the entire country, were average length of stay, your 30-day readmission rate, inpatient bed hours saved. Like, that's really important when you need to report this to your C-suite. How many hours are you actually saving them on the end so that they can still bring more patients into the brick and mortar setting? We also kept track of the percentage of patients that needed to be re-escalated back to the hospital, with an average between 7 to 10% of patients that came onto the program would need to be escalated for maybe a higher level of care that we couldn't do in the home. safety, falls, just like you measure in the brick and mortar safety, skin breakdown, falls, hospital acquired infections. We also were really tracking the race and ethnicity at UMass, just so we could show that we were serving the population of an inner city. And there's a lot of health inequities. And so we could report that out to the state that we were doing quite a service to our most vulnerable patients that were part of our community. And then last of all, let me just think, I did take a couple of notes on this one, just so that I didn't come in here blind to you. Let me find it. Uh, 30-day remits, falls, length of stay. I think that's about it.
Was it something
Is
around
what we were really tracking? Was
like
it something around what?
of your of vitals monitoring or
Yeah, and so
care plans?
Yeah, absolutely. And then from a current health standpoint, they actually can monitor. They do metrics on how often the patients are compliant, or the compliancy of using the monitor or following the tasks that we have available of measuring their own blood pressure. And so internally with current health, there's a great data science team that also tracks all of that for the programs.
Yeah, there's so much interesting data about within these schools. Okay, we're gonna go live now. You ready, Deirdre? No,
I'm ready. No pressure.
Our first question comes from Dan Castillo. Dan, do you mind unmuting yourself and asking this for the class?
Yeah, hi there.
Hi, Dan.
Thanks for the presentation, and just wanted to know, this is somewhat related to your nurse staffing answer earlier, but maybe a little tweak to the question here. Did you tend to use your own nursing, with all the staffing shortages that are out there? Did you tend to use your own nurses, or did you contract out for that service?
We used our own nurses, and I'll tell you what the key was, is you find that nurses are leaving in drones, as we all know, right?
Yep.
In keeping your staff internally in your program is so important, because you're keeping the staff within your system, right? But we generally started off with ED nurses who were experiencing high rates of burnout. And this was a whole new model that actually brought them back to the love of the profession. And that's how it was marketed. That's how we said, what do you feel that you're missing being a bedside nurse in the brick and mortar? And they all said, being connected to my patient, being able to educate my patients, and being a nurse, because they were pulled in so many other directions. And so the nurses that came to the program were all internal candidates. And it was for those reasons, because they wanted a new sense of achievement, I guess.
That's great to hear.
Yeah.
And totally makes sense. And maybe a follow-up question here, if you don't mind. What's the average length of stay that you experienced for the program?
For the program solely, or from the time that they present to ED? Because we measured two different metrics. I would say once they came on to our service, it was probably a 4-day admission, but that does not mean that they hadn't been boarding in an emergency room department for 2 days. Like a standard hospital, it was a 6 to 7 day stay.
Got it. Okay. Thank you very much.
Mm-hmm.
Awesome. Sarah, do you want to unmute and ask your question? Sorry, this Sarah, or which Sarah you are. You submitted it.
The one where nobody wants to say my last name, that's fine. Or Stadius. So my side comes from the laboratory side of it, and so our question is, do you find that the nurses do the lab collections for that and then get those specimens back to the hospital? Do you have a traveling phlebotomist that does the blood collections? How would you do this from the laboratory side?
Yeah, so now that I joined Current Health, I've seen a lot of other programs that have stood up besides what I was used to at UMass. So UMass, we did have nursing assistants that were phlebotomy trained, and also the nurses would go out and they would print their labels just like you would in the brick and mortar at the bedside, so that you could confirm your patients. And then it was a central drop off back to the lab. I do see in other programs that they have phlebotomists that just go and draw labs, just do a morning round, just like it would be done in the hospital. And then they're batched back to their laboratory, the inpatient laboratory for the hospital. And I have heard that some are actually contracting out for lab services. But my model was that the labs went right back to the central lab of the hospital.
Okay, thank you.
Yeah.
Evan, you're up, friend.
Hey, Evan.
Hi, good to talk to you again.
Good to talk to you.
So, what other logistics did you use to make your program successful? Did you use EMTs or have like an ambulance company partner that you use to make the runs to the patient when you did in-person rounding?
We had MIH. I don't know. I think that we had spoke about this in the past. UMass actually had bought a fleet of vehicles, leased vehicles, and the EMS paramedics actually had mobile integrated health vehicles. So that was actually also a draw of why nurses were more apt to apply for the jobs, because they weren't putting wear and tear on their own cars. So the fleet of vehicles is how they get transported. But if the patient needed to be transported back and forth, like say for a CAT scan that was unexpected or transporting home, we did have a contract with an outside private BLS company that we would choose either a BLS ambulance or a chair van to get them home, considering that we considered it in a transfer home, so still within our system. So it would have been an inpatient transfer, like if you were going between campus to campus. I do see a lot of programs though that are, letting family members bring the patients home, or some are using Uber to get the patients home. At UMass, we were considering them inpatients, and so always transporting via BLS or chair van. Did that answer your question?
Yeah. And then did you use any logistics software for like daily rounding? So you had that fleet of people, like, so what I say daily, like logistics software, like making your rounding most efficient. So like almost like, FedEx or some of these other companies, they only make right turns, or they only do a certain thing so that they're getting there efficiently, with gas prices as high as they are and things always fluctuating in that space. How are you handling some of those logistical items?
Evan, you and I should invent something, because we would make a lot of money for this entire group. It was all done personally by staff members. So we would meet with the daily huddles, but we would pull up a Google map and we would put everybody on a Google map, and then correlate an assignment by where the patients were located. So it was all manual labor.
Gotcha. Cool. Thanks.
Yeah.
Okay, we've got probably time for these last two. Jean, and then Ashley, you're up after Jean.
So just a quick question. For organizations that may be constrained with their clinical staff and their MAs and techs, are there good third-party companies out there that have matured that you can contract to do that service?
I think that all depends on what your organization is willing to spend. I'll be very honest with you when it comes to that. We had partnered with Massachusetts Worcester Visiting Nurses Association to do our OTPT consults, because we didn't have the bandwidth to have that internally. So that might be type of group. Your home health agency may have some more bandwidth than your inpatient services to assist with that, Jean. I have no good answer for you.
Okay.
Yeah.
Thank you. That was kind of my belief as well, that there's no good solutions out there, but I just didn't know.
Yeah. I mean, I know that there are tons of, mom and pops that service CNAs in the home. But when you're thinking about these programs, you really want people that are going to be able to do those on the fly EKGs and that phlebotomy if need be.
Yeah, I mean, we want people that work in the inpatient unit.
Yeah. So you know what is think about, they have the same amount of burnout that the nursing staff is having. So it's a great tool to recruit.
Thank you.
Yeah.
And for the virtual components of this program, we have seen a rise in a lot of these kind of clinical command centers or central command centers that kind of centralize a lot of that remote work, the monitoring, the triage, some of the escalation that frees up some of that bandwidth for the field nurses that you do have, right?
Yeah, absolutely.
Cool. And Ashley, over to you.
So I was wondering how people are handling the whole the process where the patient has to travel home as far as a consent in the ED. Are folks getting consent signed for people to join into the program in the ED, and how is that handled? Do you have field staff going in to get that signed, or do the physicians do it?
It depends on what the program. I've seen it both ways. So at time when you're approaching and screening the patients for safety for the home and kind of pitching the programs to them, once they accept, there are consent forms or enrollment forms that they will sign, similar to a treatment of care. And so it all depends on who was doing it at which facility. At UMass, we were using our case manager colleagues that were actually doing some of the screening in the department, and then the care navigators on that end that were physically going down to safety screen patients. And then I've seen other programs where it's the docs that are having them sign them.
Thank you.
Did that answer your question?
Yes.
Okay. Great questions. Thank you.
These are so interesting. We've got about 2 minutes left. Final call for questions. Anybody just want to go for it? 4, 3, 2, 1. All right. It is a Friday, everybody. Thank you so much for joining us. I hope you found this useful and interesting. If you do think of other questions that you would like to ask Deirdre, you're welcome to respond to one of the emails you got from us about this event, and we will route that to her. Follow her on LinkedIn. She's got so many great insights, and we'll probably do another one of these before too long. So
Cool.
join us again.
All right. Thanks everybody for coming.
Thanks for joining. Bye.